I have no idea if you heard any of that. So I'll start again. I started talking a little bit about kind of the initial evaluations for fertility fertility assessments here at our clinic. All right, good. We can hear you. Awesome. When a couple comes in, there are three different factors that we talk about. Three different issues that we typically can see may impede a couple from getting pregnant. The first test that we recommend really for every couple, and it's one of the easier tests to get, is a semen analysis. We look for three different factors on a semen analysis. There's the concentration, or how many sperm there are in the sample, how well they're swimming, or motility, and then the shape of the sperm, or the sperm morphology. Each of those is really important in terms of trying to figure out how fertile a man may be, and if any of those different factors are abnormal, that certainly can impede a man's fertility. There are lots of studies looking at the effect on those changes. For example, if you have a lower count, then it may decrease a man's fertility about 2 times compared to normal. If he has a low count and they're not swimming very well, there's a 6-fold decrease in a man's fertility. So semen analysis is one of the most important things to get initially. We do collections primarily here at our office. We have a private collection area that men can use, so we definitely know that privacy is an important issue. But we also offer home collection kits if men are more comfortable collecting at home, as long as we can get the sample in our lab between about 30 and 40 minutes after collection. We can't necessarily do an egg analysis underneath the microscope like we can with sperm. So one of the more common questions that we get are there tests that we can do to see if I'm fertile or how many eggs I may have left? We use a series of different blood tests where we can assess kind of the issue of the number of eggs, but also the quality of eggs. And so it gets very important to counsel patients that as they age, we know that the number of eggs starts to go down, but also the quality of the egg starts to change. And by quality, I mean how healthy are the proteins inside the eggs? Will the eggs fertilize or will they not? And if they do fertilize, will they turn into healthy embryos for implantation in future pregnancy? There are 2 different tests that we typically recommend. Both are blood tests. One is called an AMH, anti-Mullerian hormone. That gives us an assessment of, or an understanding of maybe the number of eggs left in the ovary. We don't get a specific number, but there's a spectrum, and we look on our lab assay. We typically want that number greater than 1.0 on the assays that we use. Some women have elevated numbers, so women who might have something called polycystic ovary syndrome may have a high AMH. And women, as they get older, or if they've had a history of ovarian surgery or endometriosis, may have a lower AMH. The second test that we recommend getting, especially for women 35 or over, is a test called a follicle stimulating hormone, or FSH, with an estrogen test. And we usually do that on the 3rd day of bleeding on a woman's cycle. That test tells us a lot about more of the quality of the eggs. I think about FSH kind of like the gas pedal for your car. How hard you have to step on the gas to get your car going. And so that's what FSH does for the ovary. Higher levels of FSH are needed if the eggs aren't as healthy. And so if we check those levels on day 3 of a cycle, we can get a pretty good idea of how well the brain's talking to the ovaries and how well the ovaries are responding. Now, the important thing about those numbers is it doesn't tell us if women will or will not get pregnant. What we really use those numbers for is helping guide therapy. For example, if a woman has normal levels for her age, she may need a little bit of help ovulating with lower doses of medications like pills like Clomid or Letrozole. If there are changes in those numbers, or if those numbers are abnormal, though, it may help guide us into doing a little bit more aggressive fertility therapy to help improve her chances of getting pregnant. A third test that we often do is with an ultrasound. We often use transvaginal ultrasound to take a look at the ovaries, and we count out what are called primordial follicles or antral follicles, and that also gives us an idea of how healthy the ovaries are. So those are really the 3 big tests that we do to evaluate a woman's ovarian reserve. The third test then is also making sure that the tubes in the uterus look healthy. We do use a test called HSG quite frequently. That's called a hysterosalpingogram. It's done typically in a radiology suite. We do those procedures here at TFI, where the physician puts a small catheter inside the uterus and then they inject a dye and take x-rays. And that'll show us if the tubes are open and if the uterine cavity looks normal. Sometimes women who have fibroids, we may see that on the HSG test, or if they have small overgrowths of the lining of the uterus called endometrial polyps. We can sometimes identify those as well. Importantly, sometimes that test will also flush the tubes, and that may help some women achieve pregnancy a little bit faster in the month following the HSG. That does vary between patient groups, but historically that was one of the usual teachings, that the month after your HSG is usually a little bit higher fertility time. We have limitations with the tests that we do, though, and not one test is 100% accurate. And so I often counsel our patients that even though we may see normal numbers on a semen analysis or open tubes on an HSG test, it's very difficult for us to look at function. What's the function of the sperm when they actually get up inside the tube, for example? Will those sperm really be able to fertilize an egg? Even though the tubes are open, as another example, that may not necessarily tell us that the tubes are actually working normally. Are the tubes sweeping up the eggs like they should, or are they not? And that's what's really important, to sit down with an OB/GYN doctor or fertility specialist to go over those images or the reports and really kind of focus in on the specific details. And that's something that we routinely do at the first visit. So those are really the three important first steps in terms of a fertility evaluation: getting a good semen analysis, doing some hormone testing and ovarian reserve testing for women, especially if they're 35 or older, and then making sure that the uterus and the tubes look healthy. Some of the initial fertility therapies that couples often will go to initially are pills to help women ovulate better. On average, I think it's important to understand that if a couple's been trying for over a year to try to get pregnant, if you look at their chance per month of getting pregnant without any fertility therapy, if they've been trying for over a year, their chance per month is only about 3% per cycle, or 3% per month. And that data has been around for a long time. That data comes from a study done in the late 90s where they looked at different fertility therapies compared to a control group that didn't use any fertility therapy. So we know that although that 3% sounds a little bit low, even in the second year of trying, about 50% of couples overall will still have success. But it often takes a long time, and so that's when we try to optimize the time to try to get pregnant and try to speed that up a little bit. So we can then start initially with medications like Clomid or letrozole. These are pills that women take early on in their cycle to help boost the production of eggs in the ovary. And that will typically improve a woman's chance of pregnancy to about, depending on her age, anywhere from 6 to 10%, sometimes 12% per month. The trick with those pills, though, is that they're only really helping women ovulate a little bit better. So it doesn't really do much in terms of healthy tubes and the tubes working better or getting sperm inside of the uterus faster. So if women get pregnant on pills like Clomid or letrozole, the vast majority of pregnancies that we see happen within the first 4 cycles. After 4 cycles, pregnancy rates really start to go down. And that's important to understand because that may tell us that there may be something going on with the tubes or the sperm that we otherwise can't fix with just taking a pill alone. Now, there is a therapy called IUI, or intrauterine insemination, where we can help boost pregnancy chances by about 1 to 2% each month. And that's where we process the male partner's sample in the laboratory. And that does 2 important things. One is it concentrates the sperm sample down, but it also helps the sperm swim faster. So we can then insert a very small catheter inside the uterus and inject the sperm right around the time of ovulation. And that way we're really combining the ovulation issues with getting sperm up inside the tubes better. Those pregnancy chances do change with age. So as a woman is over 35, her chance may go from, say, a 10% chance down to maybe an 8% chance, and then 38 to 40, more of a 6 to 8% chance per month. But for a lot of couples that we see, they've been on several cycles or several months of Clomid and they're still not getting pregnant. And that's one of the reasons why, is we just start to see those pregnancy rates start to go down after several cycles of ovulation therapy. The next kind of therapy that we talk about, but it is a little more, it's used more judiciously, is doing injections for hormone therapy. So these are injections of a hormone called FSH that we can give, or that the patients give themselves on a daily basis to actually help drive egg production in the ovaries. Pregnancy rates will be a little bit higher than the Clomid cycles, but we also know that more follicles will potentially develop, and that really increases a person's risk of having multiple pregnancies. And not just twins, but also the stuff that may land you on the cover of Time magazine, like triplets, quadruplets, quintuplets, so the scary stuff. So we really do work with couples one-on-one to try to make sure that we're doing things responsibly and that we don't drastically increase a woman's chance of having multiple pregnancies. We sometimes have to cancel those cycles if the response is too vigorous and if we think that it's too dangerous to proceed. So that's really where working with a fertility specialist is important. You can add IUI with the injection cycles, and so women who typically go on to injections are those who haven't responded well to the Clomid or letrozole. Women who are a little bit older, if they have some abnormal ovarian reserve testing, may respond a little bit better to the injections. So those are so it's a special group of patients that we use those injections with. And then the third form of fertility therapy is in vitro fertilization, and so that's really where we get that first idea of the sperm and egg interacting with one another. We get to look at the embryos underneath the microscope, and then we really can help improve overall chances of pregnancy because we're really starting with more building blocks. We have more eggs to work with, and it's really more controlled in the laboratory. Historically, one of the big risk factors for IVF was multiple pregnancy, but a lot of clinics, and ours included, are really focusing on putting back the best embryo that we can. And so we're really encouraging people to consider one embryo at a time if they fit the proper age category. So for women younger than 35, if they're doing their first IVF cycle, we do really encourage them one embryo at a time. If they're not getting pregnant after 2 or 3 cycles, we do then start talking about more embryos. But more embryos doesn't necessarily mean a higher chance of pregnancy. Several large studies recently have shown that putting in more embryos really just equates to a higher risk of multiple pregnancy and all of its complications. So our goal really is just to have one healthy baby at a time. And we really take a lot of time to counsel patients on that and really try to optimize care for people as best we can. So that's really the initial stuff that I wanted to talk about today. Hopefully that generates some thoughts and some questions. We did have a couple questions that were emailed today, so I'm going to take a look at those. And this may generate some more conversation as well. So we have a person who's been diagnosed with polycystic ovary syndrome. And this is one of the more common disease states that we see of the ovary. It's the most common cause of lack of ovulation or anovulation. About 7 million women are diagnosed with PCOS each year, and it's characterized by 2 of 3 different criteria. So the diagnosis, you have to have 2 of these 3 criteria. The first is any history of fewer than 9 periods in a year. The second criteria is any evidence of unwanted hair growth, either on the face, on the chest, or the abdomen, or clinical or laboratory signs of elevated male-type hormones called androgens. So we will typically draw total testosterone. So if you either have the clinical signs like the acne or hair growth, or if you have an elevated testosterone level, that fulfills the second criteria. The third criteria is a little controversial, and that's having the appearance of a polycystic ovary on ultrasound, where you see lots of these little different egg sacs that haven't ovulated yet. Studies have also shown that an AMH level, that number that I referenced earlier, if your AMH level is high, then that kind of takes the place of that ultrasound. And so we often use that for diagnosis as well. About 30% of women overall who have PCOS won't respond to our typical pills like Clomid or letrozole. We call that Clomid resistance. There are a couple different things that women can do from a lifestyle standpoint to help improve their response. Back in the late 90s and early 2000s, lots of studies looked at the effect of weight loss, the effect of a medication called metformin, with and without these medications, Clomid and letrozole. And they found that women who lost 5 to 10% of their weight who had PCOS had just as good of a response with ovulation and pregnancy rates as those women who were put on a diabetes medication called metformin. A later study in the New England Journal of Medicine looking at Clomid with or without metformin found that Clomid really is the driver of improved pregnancy rates, that metformin may help with ovulation, but that it may not necessarily help with overall pregnancy rates per se. So initially, we recommend that patients try to lose 5 to 10% of their weight loss to help their response to Clomid or letrozole. For those women who still don't respond to the pills, those are the patients that then we counsel about using those injection medications. I do what's called a hybrid protocol, where we can use oral medications first and then start adding in injectable medications. That helps in a couple of different ways. One is you typically don't get as many big follicles to develop. And the second is really a cost issue. Those injection medications cost a lot of money. And so patients can potentially save a little bit on money when they do those kinds of cycles. And we do see a big improvement in terms of ovulation rate in women who don't respond to the pills alone. The only other option, if those injections aren't an option, or if we think that it's too dangerous to go forward with injection therapy, is then to consider in vitro fertilization. We can get those PCOS ovaries to respond to medications. We can do it safely with injections with IVF. But unfortunately, just the nature of how the pills work, if a woman is still resistant to those pills, then we tend to have to go to other more aggressive therapies. So we have another question here. My husband was found to have an undescended testicle, and we've been trying for a long time without any luck. Kind of what are recommendations in terms of evaluation and follow-up? I think it's a great point that highlights the importance of a semen analysis. Initially in the evaluation, a lot of couples think, well, I, as the female partner, I'm not ovulating, I have irregular cycles, and guys might think that they're okay and that there's nothing wrong with them. But in reality, of all the patients that we see in our clinic, 40% of them have both a male issue and a female issue combined. And so we're surprised a lot of the times by getting semen analyses that may not have very good counts or motility. And oftentimes we sometimes get a semen analysis after a couple months of doing initial therapy when really there's a combined issue going on. So number one, that's why semen analysis is important. For more anatomic issues like an undescended testicle, another thing that can happen is a torsion. That's where a testicle wraps around its blood supply, and that can damage testicular tissue. Sometimes boys are just born without the testicles coming down completely. That's usually identified when boys are either infants or when they're toddlers, and it can sometimes be corrected surgically. And in some instances, the testicle has to be removed. It really depends on the case. Some men will have their other testicle may have descended normally, and that testicle may produce sperm sufficiently. One just never knows until you do a semen analysis. But even if there are very few sperm, we kind of have a different gradation of how many sperm may potentially work within insemination. So if we usually see around 8 to 10 million total sperm in the semen sample, we still think IUI may potentially be a benefit. But even in those situations where we may have very low sperm numbers, that's where IVF really does become so helpful. Where, I often tell people that, if we have 15 eggs from an IVF cycle, all we need are 15 healthy sperm. And so even men who may have anatomic issues, men who've had a vasectomy reversal, and they may have lower sperm counts, the IVF still is an excellent way to try to get pregnant and to build families. So that's a good question. There's another question here. I'm 37. My husband is 31. We've been trying to get pregnant for 3 years. I was obese and had gastric sleeve bypass surgery, and I've lost a significant amount of weight. We've been using Clomid and may want to see a fertility specialist. What might my next steps be? There's a great website that's available to the public called Life Choices in Fertility. So just Google Life Choices in Fertility. It's arranged by, and it was put up by a group of scientists, REI physicians out of California. And it's a really good interactive website where they have female issues, male issues. It kind of goes into a lot of different things, and weight is one of them. So maternal weight and the different effects of being overweight on fertility is discussed in detail in that website, and kind of gives you some good things that you can, some good take-home lessons. Anything that a person can do to optimize their health is encouraged when they're trying to build a family. It's not just a matter of trying to get pregnant, but it's also a matter of having a healthy pregnancy and a healthy delivery so that then you can have a healthy 2-year-old who starts writing on your walls with crayons. So those are the goals, and we kind of think long-term. So I'll even counsel patients that postponing fertility therapy for a couple months to try to optimize weight loss is important. We know that as a body mass index increases, especially over a body mass index of 40, we know that pregnancy rates drop pretty quickly. And we also know that there are other health issues associated with being overweight in pregnancy: high blood pressure, gestational diabetes, and also an increased risk of C-section. So it's awesome that surgeries like gastric sleeve bypass are available so women can lose weight. And our friend who wrote the question has lost a considerable amount of weight, so congratulations on that. But even with a lot of weight loss, still sometimes Clomid or other medication still doesn't work. So that's where we really need to do a further investigation into hormone testing to make sure that we're not missing anything. So I would definitely encourage you to make an appointment with a fertility specialist to have that discussion, really see what other tests are available, and then if you're not responding to the Clomid medication or other pills, what other options may be there for you. So good luck. Good job.
Okay, we have time for one more question. So this is the question here, and she means IUI, and she thinks.
So there's a question here of a patient who had several IUI cycles, but it sounds as though they were uncomfortable and there was difficulty passing the catheter. That's unfortunately not uncommon. And so there are a couple different tricks that I use to try to help with IUIs. And then the second part of the question is, will that potentially affect an IVF cycle? Being able to pass a catheter inside the uterus is of utmost importance for an IVF cycle. We want to make sure that we can deliver the embryo or embryos safely without traumatizing the cervix or the cavity of the uterus. The couple tricks that we use for either if we have a difficult IUI or difficult embryo transfer, one is having a full bladder. As the bladder fills, it pushes the uterus more in a midline configuration, more straight, so it makes the catheter easier to advance into the uterus. I've also found that using ultrasound guidance at the time of IUI can also be very helpful. If those tricks don't work, prior to proceeding with IVF, what we sometimes do recommend is having a surgery called a hysteroscopy. It's an outpatient surgery, but the benefit of that is dilating the cervix. So if there is a really tight cervical canal, that we can hopefully loosen that up a little bit by dilation to help pass the embryo transfer catheter more easily. Every person should have what's called a trial embryo transfer before they go forward with an IVF cycle. So your provider would be able to tell you that if you have a potentially difficult transfer. So we always try to plan ahead, and if we anticipate having a difficult transfer, we have a heads up about that. So because the IUIs are typically done in the office setting, most people empty their bladder before the IUI. Most people don't have complications with the IUI itself. But for those patients where we are having some challenges, those are some tricks that we can sometimes do to hopefully make that process go easier. Any other questions?
No.
Okay. I have one other question here. Is there any protocol for people with a specific, let's see, does your office have an IVF protocol for people with a specific BMI? Yeah, so each clinic is going to be different in terms of BMI cutoffs, and most of the cutoffs that we'll see will either be for offering more conservative therapy like the pills or for IVF. Historically, I found that because the chances of having pregnancy complications are so high with morbid obesity, if a woman's BMI is 45 or higher, I typically try to encourage people not to do fertility therapy, to really focus on weight loss. And if they get their BMI below 45, then that's the point where we start doing fertility therapy like Clomid or letrozole. And I based that on some actual scientific research. A good study out of Europe about 6 to 8 years ago showed that for every 1 point above a BMI of 30, that it drops a woman's fertility by about 3 percentage points compared to other women her age. So if a woman has a BMI of 40, that's a potential 30% decline in her fertility compared to other women her age. So once the BMI reaches 45 to 50, the chance of the fertility therapy working really does start to decrease markedly, and the risk of having pregnancy complications goes up. For IVF, I've historically had a personal cutoff of around a BMI of 40. And that's because with IVF, you're potentially encountering a lot of different risks with IVF. There's a risk of egg retrieval and potentially having damage to big blood vessels in the pelvis. Sometimes the ovaries don't stay in place very well for the egg retrieval, as well as increased risk when you're actually doing the stimulation protocols themselves. And then really it is more of an obstetric risk. After embryo transfer and early pregnancy, we know that those risks can go up with the BMI over 40. It's typically not a hard, fast rule. It's not set in stone, but it really takes a good conversation with your provider to have an understanding and kind of come to a mutual agreement of what BMI cutoffs would be acceptable. and really to understand why that is. So, so for my personal practice, we do have a BMI cutoff of around 40, but I do know that there are other centers that are higher and lower. Again, it's really about having that one-on-one conversation with your provider to understand why those cutoffs are in place and really how to optimize your chance, not just of getting pregnant, but having a successful pregnancy. All right. That's it for us today. I really appreciate everybody checking us out. In the next month or so, my hope is we're going to do a couple different these seminars. One of the ones that I want to do is a recurrent pregnancy loss discussion. So recurrent pregnancy loss is obviously very challenging emotionally, physically, but there is hope. There are good tests that we can do. And even women who've had several miscarriages still have a really good chance of going forward and getting pregnant. Also, probably coming up in the next year, reproductive surgery, endometriosis, as well as uterine anomalies. Those are all things that we hope to plan to talk about in 2018. Keep the emails coming. If you have any questions, you can always reach us at tnfertility.com. And our phone number is 615-721-6250. I didn't teach you that. Thanks again, everybody. Hope you have a great night. Bye-bye.